Good afternoon, everyone. My name is Kathy Ottenhoff, and I'm one of the Born coordinators. On behalf of Born Ontario, I'd like to welcome you to our provincial rounds, Maternal and Newborn Outcomes Following a Prior Cesarean Birth, the British Columbia Experience. A question and answer period will occur at the end of the presentation. Please feel free to type your question into the chat box in the lower left-hand corner of your screen. You can enter a question at any time during the presentation. As you've heard, these rounds are being recorded and they'll be posted to the Born Ontario website. So we are thrilled to have Dr. Patty Jansen with us today. She'll be discussing her research that appeared in this CMAJ Open. Dr. Jansen is a professor and director of the Master's and PhD programs at the UBC School of Population and Public Health. She is funded as a senior scholar at the Child and Family Research Institute. She is an associate professor in the Departments of Obstetrics and Gynecology and the UBC Midwifery Program. She leads Optimal Birth BC and consortium of clinician, scientists, and public health practitioners who undertake both institutional quality improvement initiatives and the development of information resources for childbearing families in BC. She conducts clinical trials and population cohort studies to evaluate interventions and models of care to promote physiological birth. Her clinical training is in nursing and midwifery. So a very big Born welcome to you, Patty.
Thank you very much, and good morning, everyone, and thank you for joining us this morning. So our cesarean section rate in Canada has reached over 21%, and that's higher in Ontario at 29%, and even higher still in British Columbia at over 30%. And traditionally, the highest cesarean section rate in the country has been in British Columbia. And therefore, women are increasingly faced with a choice to either plan a vaginal or a cesarean birth after a previous cesarean birth. And our guidelines from the Society of Obstetricians and Gynecologists of Canada recommend that planned vaginal birth be offered to women with one previous transverse low-segment cesarean section. So our VBAC rates have been declining, however. So vaginal birth after cesarean section is commonly called VBAC. And in 2011, among women with a previous cesarean birth, the rate of repeat cesarean was 81.7%. And so on the graph over onto the right, you can see that the VBAC rate has been declining over time, and that decline has continued to be down to about 28.3%. So the slide here that I'm showing you with the yellow bars is some work that we've done in British Columbia. We mentioned Optimal Birth BC, which has been a CIHR-funded project where we bring together clinicians, scientists, and academics to help our health authorities look at their practice and modify it to reduce cesarean section rate. And so in this graph, I'm simply showing some modeling that we did where we looked at each one of these factors on the graph separately to see to what degree they explain cesarean section rate in the province. So the actual values don't matter. The values correspond to a chi-square test for model fit. What I wanted to demonstrate here is how in a geographic area, previous cesarean section dwarfs everything else in terms of explaining the cesarean section rate in the province or in the health authorities we've looked at. And so if we really want to manage our cesarean section rate, we have to address previous cesarean births and the opportunity for women to have a VBAC. So how safe is VBAC? This has been a hugely controversial issue, and some of the findings are contradictory. So Wen and his group did a huge study in Canada of 300,000 women, and they reported that uterine rupture was 0.65% or 6 per thousand for women having a trial of labor or VBAC versus 0.25 for women planning a cesarean section. So on the other hand, there was a systematic review in the U.S. of 402,000 women, And in this study, they looked at maternal mortality and found that it was 0.013% for elective cesarean and 0.004% for trial of labor or VBAC. So in this systematic review, maternal mortality favored a planned vaginal birth as being more safe, as opposed to the Wen study, which was the opposite. In the Gates study, perinatal mortality was 0.13% for trial of labor or VBAC versus 0.05% for cesarean. So in terms of perinatal mortality, a planned cesarean was safer. And then another study in meta-analysis in Scotland of roughly the same size, again, pointed out that perinatal death was significantly more frequent for women planning a trial of labor or planned VBAC compared to cesarean section. The terms trial of labor and VBAC tend to be used interchangeably in the literature. There hasn't been very much work looking at how this relationship between planned mode of birth after cesarean is modified by whether or not women had a previous vaginal birth. There has been some work done on it, and as you can see, all the studies here were done in the U.S. So the Mercer study of 13,000 women found that there was a significant decrease in the rate of uterine rupture for people planning vaginal births if they had had one prior vaginal birth. And it was about half as prevalent, uterine rupture. The Zealot study, smaller study of 3,700 women, also said that prior vaginal birth was associated with significant decrease, 1/5 the risk of uterine rupture. And then the Handler study in the U.S., again a small study, didn't find any difference, and again that was probably too small to be able to find a difference. So in our study, we compared maternal and perinatal outcomes according to a history of prior vaginal birth among women planning a vaginal birth versus a cesarean after a previous cesarean section. And so our study was a retrospective cohort study using data from our BC Perinatal Data Registry for the years 2000 to 2008. The BC Perinatal Services Registry holds data for 99% of births in BC. So data is extracted from standardized birth records and merged with diagnosis and procedural codes from CIHI, the Canadian Institute for Health Information. And to check the completeness of this data, it's cross-checked with vital stats data to make sure that we aren't missing any births. And in this data set, home births are also included because home births are documented on the same form, which are sent into Perinatal Services BC. So in our study, women could have had one or two previous cesarean sections, singleton fetus, cephalic presentation, and term. And we included one or two prior cesarean sections because more and more women now are having two prior cesarean sections if they're planning a bigger family. We excluded women with pre-existing disease as well as gestational hypertension. So for our statistical analysis, we calculated the relative risks of planned vaginal versus cesarean birth using Poisson regression. In addition to calculating relative risk, we also calculated absolute difference or attributable risk. And we also calculated the number needed to treat or number needed to harm in order to prevent or incur an adverse outcome. And with our large sample size, we had adequate power to detect differences of as low as 1% between our study groups. So these are the maternal outcomes that we looked at, and we had a huge amount of discussion over months to come to this list. We had input from obstetrical anesthetists, from maternal fetal medicine specialists, from obstetricians, family practice, nursing, and midwifery, as well as reviewing the literature. And so for our life-threatening outcomes, we included deep vein thrombosis, pulmonary and amniotic embolism, uterine rupture, hysterectomy, surgical procedure to control intrapartum or postpartum bleeding. So here we're talking about things like uterine artery ligation during a cesarean section, blood transfusion, septic embolism, or life-threatening pulmonary cardiac complications from anesthesia. And our non-threatening outcomes were uterine dehiscence, so partial separation of the uterine wall, surgical wound infection, puerperal infection, or sepsis. It's hard to tell the difference between those, what either of those means in the ICD-10 codes, and long non-life-threatening complications of anesthesia. And for our newborn outcomes, we also consulted with neonatologists. And life-threatening, obviously, intrapartum stillbirth and neonatal death, APGAR score less than 3 at 5 minutes, admission to level 3 neonatal intensive care unit, the need for ventilatory support, hypoxic ischemic encephalopathy, or HIE, and intraventricular hemorrhage, or IVH. And then our non-life-threatening outcomes were APGAR score 4 to 6 at 5 minutes, the need for oxygen more than 24 hours, and we chose more than 24 hours because to eliminate those babies that were undergoing sort of brief transitional problems and had oxygen for 3 or 4 hours and then were fine. Babies that ended up in a level 2 observation nursery, and birth trauma. And so this slide shows the number of people that were in our study. So we had 33,812 people in it. Among those, 29,440 had only one previous cesarean, and 4,366 had 2 previous cesarean sections. So among the whole 33,812, we had 28,406 women with no prior vaginal delivery and 5,406 with 1 or more prior vaginal deliveries. And in the group with no prior vaginal delivery, only 26.8% planned a vaginal birth. And among those, 62.6% actually gave birth vaginally. And in our group who had had a prior vaginal delivery, 68.9% planned a vaginal birth and 88.5% were successful. So you can already see quite a big difference in terms of planning status and outcomes here. So for the next slide, I just wanted to show you this slide to demonstrate the variability across the province. So this slide represents larger hospitals with more than 1,000 deliveries in BC. It's all of the hospitals with more than 1,000 deliveries. And the yellow bars are 2007, the blue bars are 2011. And I just wanted to demonstrate the variability here because the rate of planned vaginal birth, and this is among women who are eligible for a planned vaginal birth, they don't have any contraindications. You can see that the rate goes from about 18% to 40%, and still not very high across the province. Now, we also have some Ontario data here, and this next slide is on the same scale as the previous one. So this is the data from Bourne, and you can see all of the different regions on the graph. And what's interesting about this graph is it's almost identical to the BC graph. So you can see that the rates of planning a vaginal birth are about 18% is the lowest and 40% is the highest. So pretty much identical to what we were seeing in BC. And this next slide is also Bourne, Ontario data, and it looks at the same question but divided by hospital level of care. And so the highest rates of VBAC are at the higher level of care, level 3. And then this next slide is the percent of women who had a successful VBAC among those who attempted VBAC, and again, looking at Ontario data by regions. And what's interesting here, again, is these high rates of success. So they go from over 60% to 80%, and generally averaging out about 70. And when we look across our province at each one of our health authorities, these high rates of success are universal across the board. And it suggests to us that there's the opportunity to have more successful births if we were to actually offer it to more women and more women were willing to try it. So it seems that there's room to improve in terms of raising our attempts to plan vaginal birth. And then this slide is just one health authority. I don't want to identify the individual health authority, but again, I wanted to show you, even within one health authority, the variation in rates of attempted VBAC going from 25% to 57.6%, and then success rates from 60 to 88%. So both attempted rates and success rates are quite similar between BC and Ontario. So just getting back to our study again, this was the first table in our study, and I just wanted to show here that our comparison groups were relatively similar. So women planning a vaginal birth were slightly younger and more likely to have a normal or low BMI. And in all of the other variables that we looked at to compare the groups were similar. So starting to look at our outcomes then, for maternal outcomes, we had no maternal deaths in our study, and we made a composite outcome because the outcomes we were looking at were so rare that we said that our composite risk would be one or more life-threatening outcomes. And so for the people that had no previous vaginal delivery, we reported a relative risk of 2.52. So in other words, higher risk of an adverse life-threatening outcome if you had planned a vaginal birth. Now, one thing I wanted to say here is we're reporting relative risks and not odds ratios because when we adjusted for BMI and maternal age in our models, it didn't change our odds ratios significantly, less than 10%, and therefore we're reporting relative risks instead of odds ratios because once you get to outcomes that aren't as rare, the odds ratios, as I'm sure you know, are inflated and don't represent the data as well as relative risk, which represent the true risk. And so that is why we're representing relative risks here. And I also wanted to point out that if you look at the percentages here, they're not very different. So all of the numbers in brackets are percentages. So if you look at no previous vaginal delivery, for planned vaginal, women planning a vaginal birth, the rate of life-threatening outcome was 2.2%, and for those planning cesareans, it was 0.9. So even though the relative risk is over twice as high, 2.52, those actual numbers are 2.2% versus 0.9%. And then very similar numbers here for women with one or more previous vaginal delivery. So in looking at this particular outcome, having had a prior vaginal delivery did not substantively change our outcome. So what I'm showing you here is just some of the components of that composite outcome for life-threatening outcomes for moms. So if we look at surgical intervention to control bleeding, it was significantly increased for women planning a vaginal birth, both without a prior vaginal delivery and with a prior vaginal delivery. And I said earlier that we had calculated numbers needed to treat or harm. So the number of women that would have to plan vaginal birth in order to see adverse outcome is 76 among women with no previous vaginal delivery, and that same number is 99 for women with a previous vaginal delivery. So blood transfusion significantly elevated only for women planning a vaginal birth without a prior vaginal delivery. Looking at uterine rupture now, significantly increased only for women planning a vaginal birth without a prior vaginal delivery. Again, the relative risk here is 6.93, and I'll show you the numbers in a moment. And uterine dehiscence was significantly increased only for women planning a vaginal birth without a prior vaginal delivery. So looking at non-life-threatening outcomes, among women with no previous vaginal delivery, relative risk is non-significant, 0.99, and for women with one or more previous vaginal deliveries, our relative risk is 0.51, and so there's a significant decrease in risk of non-life-threatening outcomes if you've had a prior vaginal delivery. So this next table is just taken out of our paper, and I don't expect anyone to look at all of these numbers. I'm only wanting you to look at the numbers in brackets for a moment here and just appreciate that the actual numbers are quite small. So if we look at uterine rupture under no previous vaginal delivery, so the first two columns, in other words, looking at uterine rupture, for planned vaginal it's 0.4 or 4 per thousand, and for planned cesarean it's 0.06% or 0.6 per thousand. So the actual differences in terms of numbers that you would be telling a woman would be your chances on planned vaginal birth are 6 in 1,000. For planned cesarean section would be 4 in 1,000 for uterine rupture, and for planned cesarean it would be 0.6 per thousand. And those are the two numbers that they would need to be thinking about in order to make their decision. And so we're also looking here at non-threatening outcomes, non-life-threatening outcomes, and you can see going down the two left-hand columns, again, the differences in percentages there are quite small. So we're mostly looking at 8 per thousand or less. And so now, moving on to fetal and neonatal outcomes, we looked at the composite risk of stillbirth, neonatal death, etc. And these were significantly elevated only for women planning a vaginal birth without a prior vaginal delivery. So if you look at women with one or more previous vaginal deliveries, there was no significant difference between women planning a vaginal birth versus a cesarean birth. And once again, if you look at the numbers, under no previous vaginal delivery, we're comparing 8 per thousand with 5 per thousand. And under more than one previous vaginal delivery, we're comparing 4 per thousand with 7 per thousand. Looking at some of these outcomes individually, the 5-minute APGAR, less than or equal to 3, was significantly only for women planning a vaginal birth without a prior vaginal delivery, and admission to a neonatal intensive care unit significantly only increased for women planning a vaginal birth without a prior vaginal delivery. And then now looking at non-life-threatening outcomes, significantly decreased for women planning a vaginal birth with a prior vaginal delivery. when we look at no previous vaginal delivery, there was no difference between the groups. And these tables, again, look at all the individual outcomes. And once again, I'm just showing you this table so that if you look in the brackets on the two left-hand columns, you can see the actual numbers that would need to be presented to women in order to help them make this decision. And so if you're looking at, if we look at ventilation, for example, it's 2 per 1,000 planned vaginal birth, 2 per 1,000 planned cesarean. So those are the relevant numbers for women to know. So most of the women in our sample had only one previous cesarean birth. And since a lot of the literature and the SOGC guidelines address people with one previous cesarean birth, we wanted to analyze that group separately. And since that group was the majority of people in our sample in any case, we found that there was no difference in our findings. So the direction and size of differences for each outcome group according to planned mode of delivery was similar to those for when we looked at people with 1 or 2 cesarean sections. So our main findings were that the association between a planned mode of delivery and adverse outcomes after 1 to 2 previous cesarean sections may be modified by history of vaginal birth. So I'm just having trouble advancing this slide. I don't know if you can advance it for me.
I'll give it a try, Patty. Sometimes as the presentation moves on, it just gets a little bit slow.
Okay.
Sorry, now it's jumping ahead. There
Okay,
you go.
so what I wanted to just touch on next is some of the limitations of our study. And as always with these large studies, we were using retrospective data. This was an observational study design. Obviously, we weren't able to randomize people to one group or the other. We had to use composite outcomes for our statistical analysis because our outcomes are too rare to look at individually. And we also, of course, didn't have as much power because our group of women with a prior vaginal delivery was a small group. And we did not have data on race ethnicity. We also did not have data on inter-pregnancy interval, which would have been an important thing to look at and something that should be looked at in future studies. The other thing that we did not have in this study, which is very important, is that we were not able to control for the indication for the first pregnancy. So for people doing this kind of work, you would hope to be able to control for whether or not the indication for the first cesarean was a factor that would go on to continue to be a risk factor for cesarean birth. So in other words, someone that had an initial cesarean for a breech presentation and then someone that had an initial cesarean section for dystocia could be expected to have differing probabilities of successful VBAC and adverse outcomes. So the other thing that we also couldn't look at and may be important is what the role of the primary caregiver is, whether that primary caregiver is a family practice physician, a midwife, or an obstetrician doing primary care. So I'm just going to move on. Did anyone else, did the screen go blank for you all here?
We're on conclusions now.
Okay, because I'm just being, I'm not quite caught up to you, but here we go. So our conclusions are that overall, the risk for adverse outcomes after 1 to 2 previous cesarean births are reduced among women with a prior vaginal birth compared to without a prior vaginal birth. And so I think the take-home message here is that if we're concerned about offering women VBAC, we should at least be offering VBAC to women with one previous vaginal delivery. And often that isn't emphasized with women, that the probability of success and better outcomes is higher if they've had a previous vaginal delivery. And the second take-home message, I think, for clinicians and for women is that the absolute differences between planned vaginal birth and planned cesarean birth are small. And often when we hear things like a relative risk of 5 or 6, that sounds horrendous. Who would ever plan a vaginal birth if they were looking at twice as high a risk of uterine rupture or even higher than that? But then when you say it's a difference of 2 or 3 per thousand, that helps people put that into perspective. And then lastly, we wanted to offer women and their providers the opportunity to consider risk profiles separately for women who have had and not had a prior vaginal delivery, for women who have had one prior cesarean versus 2 prior cesareans. And when we looked at just that small group of women who had 2 prior cesareans, we did not have enough power to report statistical differences between those, but we did not see differing trends after 2 prior cesarean sections compared to after 1. So it gives people the opportunity to tailor their discussions around risks and planning a little more closely to their own situation. So I'm ending a little bit early here, and I'm giving us lots of chance for discussion because I think people will have a lot of questions and ideas about this data. And this is, to my knowledge, the first Canadian data that's come out and actually looked at this question in the context of a prior vaginal birth. So perhaps we could open it up to questions and discussion.
Thank you, Patty, so much. So just a reminder to everyone, type your questions into the chat box on the lower left-hand corner of your screen. And we have one at the moment, and Patty, it says, was induction considered when assessing outcomes?
Yeah, thank you very much for bringing that question up. And I should have said this earlier, we excluded women with an induction because we know about the controversy about whether people should be induced when they have a uterine scar, and so we eliminated those women.
Thank you. And just while we're waiting for another question, I just wanted to remind the hospitals there are a number of born reports available to assist you in looking at your C-section and your VBAC data. You can find distribution of VBAC, including VBAC success rates, your distribution of primary and repeat sections, and of course our Robson cesarean section monitoring report. And if you need help delving into your VBAC data, your section data, just give your born coordinator a call, and we're always happy to help you accessing these reports.
And Kathy, for the midwifery practice group users, the clinical standard reports, the midwifery care profile birth also has a tab that has VBAC information, and it's divided up by primate small tips and whether or not there was more than one prior C-section.
Oh, that's great. Thank you, Vivi. Vivi's our midwifery coordinator expert in all things midwifery at Bourne. So I'll give it a few more minutes for chat box.
I'm also wondering if anybody heard anything unexpected. Were there any surprises for you? Or if anyone would like to comment on our low rates of attempted VBAC and whether or not you think we can increase those at all.
Good question, Patty. I know for myself, I'm, always wondering, and it's something that the hospitals can get out of the Bourne reports, is that it's amazing to me that the rate, when you look at the rates of successful VBAC, they're so high, and yet the amount of women declining. So you wonder if there isn't a gap in getting that information to the women so that they can make an informed choice.
We're doing a lot of work on this with optimal birth in British Columbia, and one of the huge barriers that we have is in our small rural hospitals where there's competition for OR time. And the hospitals are reluctant to offer VBAC because they can't predict when the OR will be needed, and they're not very happy to have to have an anesthetist walk out of an OR where there's a cancer surgery on or an orthopedic surgery on and into the next room to put in an epidural and stay there for unplanned cesarean birth for someone doing a VBAC. And so some of the debate there is problem with obstetrical anesthesia coverage not being available, and whether or not within a health authority women should just go to the major hospitals to do their labor if they're doing a VBAC. And then the controversy and trouble over that is that it means that their physicians need to get privileges in a different hospital and travel to a different hospital, and that hospital will be one where they're not familiar with the setup, with the nurses, or anything else. And so that takes some getting used to with some initial safety concerns. And then for women who are used to living in a community and using their own community hospital, they don't necessarily want to drive 2 hours to another hospital to have their baby, especially if they're in labor during that drive. So those are some of the issues that we're working with. And we have also done some qualitative studies around this. And one of the things that we've learned is that the decision to plan vaginal birth or cesarean happens between pregnancies. So by the time you're into the pregnancy following the cesarean birth, it's too late. Women have decided, and they've decided based on discussions with friends and family and internet information. And during this time of decision-making, they're away from their healthcare providers because they're not pregnant, so they're not talking to the doctor or midwife. And so the challenge is how to get them the information that's relevant and timely when they're ready to consider that. And so what we're trying to do here is we give women a pamphlet on VBAC before they leave the hospital. So when they have that cesarean section, they get an information pamphlet before they go home. And we're trying to set a standard so that every OR report actually states whether or not there's any contraindications or reasons not to offer VBAC next time, so that in the following pregnancy, the care provider can immediately see in that chart what the conclusion of the surgeon was right after that cesarean. So those are a couple, among other things, that we're doing to try and promote higher VBAC rates. And I'll just stop there for a moment if there's any more discussion or some questions.
That's great. And I think you answered the next question that popped up here, Patty, was what do you think are the provider barriers to encouraging VBAC? I think you addressed some of those.
And by the way, I'm disconnected here again, so I'm not able to see those questions. So provider barriers is also something that we've done qualitative research, and we've done it around the province. And one of the huge ones is, concerns about uterine rupture and safety and litigation. And that differs from region to region. And so what's been really interesting for us is going to our Northern Health Authority, where sometimes the roads are just impassable in the winter, and there's much more of a culture there of trying to promote VBAC. So in that difficult geographic setting, the standard now is VBAC, and they're going from suggesting VBAC or simply giving women numbers and asking them to weigh the decision to actually recommending it and following the SOGC guidelines on that. And how they approach this from a risk management basis is the community knows when someone is going to be planning a vaginal birth, and when they come in labor, everybody knows it. The nurses know it, the physicians know it, the surgeon on call knows it, the anesthetist knows it. Regardless of what the anesthetist is doing or where they are, they're informed when the women come into hospital, and the hospital is planning around that VBAC and doing contingency planning and planning for staff to potentially have to stay late or come back. And the whole idea there is around making it work somehow. And then the other thing that care providers do in more remote locations is they talk to women about risk and about the research and what we know about complications, and they tell them that they should really be thinking of those numbers as being higher when they do their considerations because of the transport time that's going to be involved. The other strategy that people use is that they leave their community and they go to somewhere where they are going to be closer to a hospital. And, even here in the city of Vancouver, next to St. Paul's Hospital, there's a big hotel, and there's three rooms in that hotel reserved just for pregnant women in labor, so that if they are coming in from out of town, they use it for home births, but aside from home births, they also use it so that women can be really close to the hospital if they need to suddenly come in quickly for concerns during early labor for women attempting VBAC. So this is some of the strategies that are used by caregivers and clients around the province.
Thank you, Patty. Just on the continued topic of provider barriers, we have a comment from one site that says, another issue that we seem to encounter is that the physician discussing options for delivery and counseling the patient during pregnancy is not the physician that ends up delivering that patient. So I'm assuming maybe they're getting one type of counseling in pregnancy, and then when they come in labor, it's different counseling.
And I think that really raises the question of how do we standardize counseling, and also what we learn from our colleagues who are experts in health literacy and communication is that we really should be using decision aids that incorporate shared decision. So it's not just providing women with information and then discussing. It's something where women state their values, how important things are to them. Caregivers can also state their values and what they're concerned about, and together they come to a mutual shared decision-making point. And that kind of interaction can be standardized through shared decision-making tools. And so that's what we're hoping to develop. And BC Women's uses a very lengthy consent form now that has all kinds of diagrams, etc. on it. And what it does is it tries to explain to women what risk means. So if your risk of something is 2 in 1,000, like what does that compare to in everyday life? What's your chance of being in a motor vehicle accident or being struck by lightning, etc.? And at the end of this consent form, you need to actively choose VBAC or cesarean. So there's no default. You have to choose one or the other. And so that's an attempt to standardize this discussion process and to make an active choice, not a default. And so this whole has been a campaign on it, BC Women's, and I don't know if you've heard of it, but it's called Keep Calm and VBAC On. And the first part of it starts with a cesarean and careful documentation in the OR report to talk about the suturing, the closure, and suitability for VBAC next time. That's followed by the VBAC pamphlet that they get before they leave the hospital, and they also get information about a VBAC clinic, which is another option for a health authority to consider, where women can, in some of these remote areas, can come to Vancouver, assuming they can afford to get there and they have someone to look after their other kids. They can come down, and those physicians working out of that clinic will provide them with care during labor and delivery. And finally, the more complex and more active consenting process when they do come into hospital. But again, I think that the approach to VBAC has to be in a region. It's not just about clients and their caregivers, because caregivers are also constrained by the limitations of hospital size, geography, everything else. So it really has to be on a much higher level that the whole question is tackled from sort of multifaceted arenas, and bringing in anesthetists and nursing and everyone else to try and sort this out, and to consider this not just as a clinical issue but as a public health issue, because how do you reach women between pregnancies and give them evidence-based information when they're actually making the decision between pregnancies? And then the other thing that I wanted to touch on that has been hugely important as we've done the qualitative research is the amount of trauma that women experience for their first birth. So keeping in mind that many of these cesarean sections were emergency cesarean sections, women need to recover from that trauma, and many of them aren't recovering from it because they don't talk about it to their caregivers. Their opportunity to discuss their previous cesarean section has often happened during a period where they were still traumatized, not processing information well, and for them, a way of coping with this is to say, next time cesarean. I'm never going through that terror and that fear and that worry for my baby. I'm having a planned cesarean. And so in our qualitative research that we carried out in 8 different settings around the province, we heard this loud and clear, the need to debrief more after that cesarean section at a time when women were really feeling like they could process the information, and that the woman would not necessarily present herself to a caregiver as someone who was in trauma. It was something that needed to be brought up by the caregiver and discussed in some detail, and then help to work through that and feel that she had, an active role in participating in the next birth. So those are some other issues that need to be addressed in kind of the big picture.
Thank you, Patty. Another comment here about physician barrier. It says patients tend to go with a repeat section because it's booked with their pregnancy provider with whom they've established a relationship. So I'm assuming meaning that you're going to get your cesarean section by your pregnancy provider instead of getting whoever's on call if you came in labor. And I think that really speaks to the comments that you just made about this being larger than something between just the patient care provider and the woman. It goes to a much, much higher level.
Yeah, and that's a tough one. So I know that we have midwives listening, and I think that some of the ways that that's been dealt with in midwifery practices, first of all, there's very small call groups, and so people have a chance to meet other midwives and don't feel like they're dealing with a stranger. But certainly we have call groups in both family practice and obstetrics where there are opportunities to meet the other caregivers in kind of a relaxed evening setting. And so people are not so worried about the fact that it won't necessarily be their care provider. One of the things that they do, for example, in Terrace, which is one tiny place in BC, it's got one of our very, very lowest cesarean section rates. They decided that the labor and delivery nurses ought to be giving the prenatal education. And so they bring pregnant women into the hospital to meet the LDR nurses and have a little orientation to the hospital, whether this happens for nullus and multips. And so when those women are coming into the hospital, they feel like they know someone because they met a lot of the nurses and felt welcomed. And when they come into the hospital, there's a very good chance that they're going to be greeted by someone who knows them, remembers their name, and will greet them warmly. And so that's been another factor that those hospitals have identified as making women feel more comfortable coming into the hospital and working through their labor.
That's great. Another comment just saying, and I think another barrier, the adage that wouldn't a C-section be easier to schedule and manage from a planning perspective? And I think you've touched on that a little bit.
Yeah, and that's exactly right. And I think that planning a cesarean section makes everybody's lives easier, including the women who are planning it, in terms of planning their own personal lives. But what I think people don't realize is what the downside of a cesarean section is, as we're learning more and more about risks to women and babies of cesarean birth versus vaginal birth. And so I think that aside from the question of VBAC, we're not getting that message out there that we are learning more from huge Canadian and American studies of what the consequences of cesarean birth are to women in terms of complications, infections, et cetera, and now concerns about babies and necessary adaptations in their immune systems that happen with vaginal but not cesarean birth. So to me, that's another public health message, and we really need to be thinking bigger in terms of educating the public in general, not just our clients, and also how these questions are addressed in health authorities overall. And then the other thing to just keep in mind is it should be a strong motivator is the cost of doing cesarean versus vaginal birth.
And that kind of leads into another question I have here. It says, how is VBAC affected by funding? Is it considered higher quality and funded more generously when compared to those who have a repeat cesarean section? I believe it's the other way around, isn't it, Patty?
Yeah, the doctors are not incentivized one way or the other, so it doesn't matter to an obstetrician really financially, but it definitely costs the hospital a lot more to do a cesarean birth than it does to do a vaginal birth. Mm-hmm. I just wanted to make one brief comment also on Obamacare and how that's changed shared decision making. In the U.S. right now, for health maintenance organizations who are funded and subsidized through Obamacare, they're required to provide proof that they are doing shared decision making. And the way that works is that there's now software programs developed for prenatal education where you're going to know the topic of discussion before you come to a visit. And you're going to be sent some articles and patient information materials, and you're meant to read them, and then you're sent some questions about those, and you are to answer the questions and forward your questions to your caregiver. And so an email dialogue or a texting dialogue goes on between client and caregiver before the prenatal visit. And so at that visit, the quality of the discussion can happen at a much higher level, because that previous discussion has gone on and women have had a chance to ask more detailed questions or look up more literature. And in order for these HMOs to continue to be funded by Obamacare, they need to provide evidence that shared decision-making has happened. So I think this is where we're going. We're going to have to do this, and hopefully that will, we'll develop the tools to do that and be better prepared.
Thank you, Patty. So it's 5-1. Just wanted to mention that our next scheduled Born Provincial rounds won't be until September the 15th as we break for the summer months, and we welcome any suggestions for future webinars. You can submit your topics to your Born coordinator or email us at information@bornontario.ca. So stay tuned for upcoming announcements on the topic and the presenter. Just looking to see. There's a question here. It says, why VBAC? How VBAC is part, sorry, we'll go back a little bit. It's a question from Ryan. Sorry, Ryan. Why is the culture in Northern health authorities more geared towards VBAC? The second part of his question is how VBAC is part of the culture in the North. It seems counterintuitive given the larger distances, poor roads, etc.
Yeah, that's a great question. Thank you. And it is interesting because we have seen rates of VBAC go way up both in Prince George and in Terrace. And Terrace is quite a remote community. And these are very recent changes. So historically, rates of VBAC have been not only low, but in some places non-existent in the North. And this is purely a leadership issue of new obstetricians coming to that setting and saying, we're going to do VBAC. And they're opinion leaders, and they have created that culture and worked with the whole team around them to think about ways that they can best support women. And they do talk about enhanced risk in relation to their setting, and they certainly encourage women who want to go south and stay with family, etc., to have VBAC to do that. But many women in those communities can't. They have other children and they can't afford it. So in that setting, they just work around it, and they don't shy away from the risks, but they do talk about absolute numbers, not relative risks, and they promote planning care so that they can accommodate women.
It's amazing. So thank you, Patty. We're just about out of time, so thank you, Patty, for that excellent presentation on maternal and newborn outcomes following VBAC and providing us with information to consider for sharing with women to aid them in making an informed decision regarding birth after section. So thank you for everyone for listening. Thank you for your attention. And as usual, any questions or concerns can be directed to our Born coordinator. And as I mentioned, this presentation with the slides and the recording will be posted on our website, bornontario.ca, within the next week. So thank you, Patty. That was awesome.
Okay, thank you.
Bye, everybody.